Good afternoon. Welcome from the lunch. Uh, and this session, uh, I'm calling Dr. Ragini Parekh, come on the dais. Dr. Navneet Tosniwal, please come on the dais. Dr. Sumit Lahane, come on the dais. Now this is the course which is going to discuss newer technologies in the Phaco emulsification, and myself is going to talk on how to make an optimum use of newer technology in Phaco. So my talk please. Sumit, come on the dais. Navneet, come on the dais. Good afternoon. Uh, now we are everybody is thinking of the Phaco, and I think today, though the femtosecond is there, the Phaco is the surgery of cataract today. Now you will ask me, you are doing SICS? Yes, I am doing SICS. I am an SICS surgeon. But the ultimate from SICS, you will have to travel to the Phaco emulsification. So SICS is a step, and I am doing this SICS in the rural Maharashtra. Now this, I am going to talk to you about the machines. My financial interest towards any company is zero, but I want all the companies should support to the conferences in the AIOS or also the state conferences. That is what is my interest, and I always talk to the people of the trade. So my personal interest is zero. Now see, if you think of the evolution, and in the evolution, as you know, gradually we were doing the intra, then extra, then we came to the SICS, then we came to Phaco, and after Phaco now we have gone to the femto. So the femto, yes, we are there up to the femto. Now these are the all machines you can see. These are all companies, not one company, all company machines. And at the end of the talk, I am going to tell you what machine you can purchase and why you should purchase that machine. Now I am not going into the more basic that I understand, and because of that I am going to the above basic, the fusion fluidic system. Now this both peristaltic and the venturi pump options in this system, two handpiece, that is the ellipse and the ellipse FX, which combine both longitudinal and elliptical motion into a single handpiece. So both motions are together in a single handpiece. Now in the Y-star technology, the advanced micropulse Phaco emulsification technology, here the micropulse is used, but this technology combined modulated ultrasonic power, that is pulse shaping, ultrasonic power, pulse shaping with a vacuum control through the use of chamber stabilization environment. Here there is a chamber stabilization, that is a CASC. So that is there in the Y-star ICE technology. Now the occlusion mode Phaco independently control the aspiration rate and the vacuum rise. These are two separate controls for this, and program the power modulation of the Phaco handpiece, that is a continuous pulse and burst, to automatically change when the Phaco tip changes. It means these continuous pulse and bursts are automatically comes in when the Phaco tip changes from an unoccluded condition to an occluded condition. Once you occlude, the Phaco tip itself will be continuous pulse or burst as per requirement in the cataract. And the fusion, what is the fusion now here? Allow the case, that is the chamber stabilizing environment and occlusion mode Phaco can work together or independently. See, both Phaco can work together or independently. Now the compact intuitive system. Now intuitive means what? Intelligent. We can decide itself. And this is the proactive intraocular pressure, that is here like an Alcon, the IOP is managed by intuitive system here. And then we will see the Stellaris elite. Now adaptive fluidics is there. So different modality, now stabilizing the intraocular pressure. So here the adaptive, this fluidics is used to stabilize the intraocular pressure. And attune energy. See the attune energy, that is controlled emulsification within 6 crystals, that is 2.8 this handpiece, and the frequency full, that is full frequency 130 micron stroke length. I always say that whenever you are purchasing any machine, you will have to think of the stroke length, and when the stroke length is better, then only you should purchase the machine. So that is what about the stroke length. Now the CMICS, that is a coaxial 1.8 millimeter coaxial microincision surgery or 1.8 mm microincision surgery is possible because of this Stellaris elite machine. Then the torsional ultrasound, that is OGIL. It is born in 2006. The Centurion vision system was introduced in 13, and two major innovations, that is an active fluidics and the balance tip. Two major innovations were there in this machine. And now Alcon infinity system is an OGIL intelligent Phaco. Now see, there we have seen the intuitive Phaco, that Phaco is going to decide. Here it is an intelligent Phaco, that our IP, the original OGIL consists of the oscillating side to side motion by a Phaco tip. So there it is a side to side motions are there in the oscillations or OGIL. Now what happens in IP, that I am going to tell you. Now see, this is the gravity fluidics. See, it was used a bottle, and you can see the intraocular pressure, that is millimeter of mercury. Here is the machine, and the bottle height is decided by the foot pedal. How much we are pressing the foot pedal, accordingly the gravity fed reflex is working, and you can see now intraocular pressure is changing from 20 to 60, 70. Can you see? And you can see the iris diaphragm is coming forward. It means the chamber maintenance in the gravity fed reflex is not proper. That depends on your foot pedal, and this foot pedal decides. Now here you will again see the vacuum, the IOP, and the vacuum if you have kept the 500, then now here again you can see the 50, and you can see the bottle. The bottle is bound both sides, they compress the bottle. The bottle is compressed, and that compressed bottle, now here it is a gravity fed, again you can see gravity fluidics, the millimeter of mercury, whatever you do, that is going to change, but here you can compare when it is a bottle, that is compressed bottle technology used, that is an active fluidics. You can see intraocular pressure is maintained 49-50, that is at the optimum level throughout the procedure. That is what is there because of the compressed bottle technology in the Centurion machine, which was not there when it was a gravity fed or with the bottle. Now see, this is the same, you can see the both start that, okay. See now, the both the, can see the nucleuses are near about same. You can see the left side. Here I am not using IP, it means longitudinal Phaco. I am using only torsional Phaco. Can see here, and there you can see I am using the longitudinal Phaco. So what happens? The Phaco, which is Vogel, that is always useful for the occlusion. Useful for the occlusion, but longitudinal Phaco is useful for the cutting. It means if you use the Vogel only in that, you will see here it is using torsional Phaco, that is having the movement, but with this, though I have kept at 70, intraocular pressure is maintained, I am using the vacuum also, but I am struggling by the same machine. By the same machine, it is not a different machine. But if you will see on that side, I have made the two pieces, and there you can see the longitudinal Phaco is working. Now when it works? When the Phaco, which is torsional Phaco, has occluded. The torsional Phaco has occluded. The intelligence Phaco start its work. Now what is the intelligence Phaco? When the torsional Phaco has occluded and then you want cut. The cutting is done by the longitudinal Phaco automatically. It is not required that you should move foot pedal or like that. So that is what IP, intelligent Phaco mode. It is a software, and that is there in the Centurion machine. So you can see on the left side that I am making the pieces, and these pieces will be separated properly. That I will show you. Now I will just show you this, the what is IP. Now see the here, can see now I am going in. You can just look at the two places, 120 on other side, you can see light there. Once there is a light, longitudinal Phaco start working. Again you see this is what is the indicator, an indicator light, then longitudinal Phaco. It means once I occlude and the Vogel or torsional is not working, that time if required the longitudinal Phaco works. If not required, longitudinal Phaco doesn't work. So here see now I am making the separation. Again you can see now once I go in, okay, and you can see once I go in, can see the per cut the longitudinal Phaco works, and though it is a hard cataract, I can make the pieces of this cataract. So again you will see I am going in, and once I go in here you can see just rotating the, and now again you can see the longitudinal Phaco is working automatically, and those are the hard pieces, but see longitudinal 75, torsional 75, and the vacuum is also there. Intraocular pressure I have kept at 70, but if it is kept at 40 or it is kept at 50 also, it works properly. But if it is kept at 30, you will have to do very slow phacoemulsification. Otherwise you can damage the PC, but 40 and above, yes, the Phaco is possible. Now see again how that is entering inside the hard cataract, but here you can see whenever it is entering, the longitudinal Phaco is working and torsional Phaco is working, and because of that I am doing both cutting, occlusion and aspiration. So that is what is there, and in the hard nucleus you can remove such type of nucleus in the IP Phaco. Now the second thing is, now in this this is the indigenous Phaco. Now here this is the APA machine, Galaxy Pro Orbit. Now here that is the pulse, micro pulse, burst, everything is there. Now this is first APA machine that I am satisfied, as this is an indigenous. See now I am making the pieces in the APA machine. Up till now I always told APA is after service is very good, after sale service, but here Every time the Phaco was having only occlusion mode and no penetrating mode. Now first time in this orbit machine there is a penetrating mode. So the machine is also penetrating inside the nucleus. That may be very hard. I have operated grade 4, grade 5 also, and that machine is working very well. So they have got all micropulse, burst, and the even the continuous mode, and that is working very well. So I think with this I am very much thankful to you. And now the next Sumit Tekar, Sumit sir. Hello. The next talk is of the Dr. Sumit Lane, and he is going to talk on the how to use Phaco dynamics modalities to overcome difficult situation in Phaco. So he is going to talk about the Phaco dynamics.
So Sumit is an MS ophthalmologist. He has also done a fellowship with Dr. Rohit Shetty for 1 year in refractive and Phaco and 1 year with Santosh Honavar. He's a graduate of Sir JJ Hospital, Mumbai, and incidentally he is also Dr. Lani sir's son.
Thank you, ma'am, for the introduction. I would be talking about the how to use this Phaco dynamics for the difficult situations in the Phaco emulsification. This will be just going through the basics again. We have no financial interest in any of the machines shown. So the Phaco dynamics, as we all know, it's mostly about the sonics, that is nothing but the ultrasound energy, fluidics, which is the movement of the fluid, and the technology which comes and evolves with the every machine. So Phaco dynamics, when we are talking, it's basically the electrical energy which is converted into the mechanical energy with the help of the piezoelectric crystals. Types of the aspiration pump, majorly what we use are the peristaltic or the venturi pump. The difference between them, the peristaltic is better to known as a safe machine, as there is slow vacuum rise time, there is flow rate and the vacuum that can be dissociated, less followability, but it is better for the beginners. Venturi on the other hand, the flow rate and the vacuum cannot be dissociated, and the vacuum rise time is very quick, especially after the occlusion, and there is more followability, and it's better for the faster surgeon. And this is the way the emulsification is been done, depending on the pneumatic drill effect, cavitation, torsional and the longitudinal Phaco, transmission of the acoustic waves, and the impact of the liquid particles. So as every machine normally has modes, which could be continuous mode, which could be pulse mode, or which could be burst mode, that is single or multiple. So now this mode should be used differently depending on your depending on the cataract grade that you are operating. So you need to change your settings depending on the type of a cataract that you are operating on. Continuous mode, it's actually linear, so there is energy that is being utilized for every movement that you are pressing the foot pedal. So this is better for the sculpting, that initially when you are doing divide and conquer to make a groove inside the nucleus, let it be hard or the soft, this can be very well used. The problem with the continuous mode is that the energy dissipated is much more, so if the endothelium count is poor or there is the very hard cataract, you might end up using very high energy. So this should be used only initially in the Phaco 1, especially when you are dealing with the hard cataracts. With the soft cataract grade 2, grade 3, you might not need also. With the pulse mode, then again you can set your pulse mode depending on your machine. Either you can keep the duty cycle of the 50% or less than that. What is the advantages of the pulse mode? As we all know, it's all about on and off cycles. So if you keep your pulse with on and off 50% of the cycle, the energy from the Phaco is dissipated only 50% of the time. So it can be used for the quadrant removal approach with the 50% of the duty cycle or the less, cause in the quadrant removal you don't have to emulsify much. The maximum work is done by your vacuum, so you can keep the vacuum at 300, 400 on the medium size depending on the type of the nucleus, but the pulse mode can be very well used. And even the low power can be used if you are trying to remove the epinucleus with the Phaco piece itself, then you can do with the low power pulse technology. There is also something called as a hyper pulse, which is available in the few machines, and that can be used for the like it can be used as a burst mode, especially in the hard cataract, that you can use even for the sculpting nowadays. Burst mode basically is a combination of both pulse and the continuous mode. What happens in the burst mode is that as you keep on pressing the foot pedal, the pulse keeps on increasing, and theoretically you can say that when you press the foot pedal completely in the position 3, you actually convert your burst mode into the continuous mode. So with the burst mode you can do the entire Phaco also, and you need not change your mode again and again. So with the this burst mode, you can actually, with the full foot pedal, you can try to sculpt and divide the cataract. With the foot pedal in the mid stage of the position 3, what you are using is basically a kind of a pulse mode with the medium power that can be used for the removal of the quadrant, keeping your vacuum high. And foot pedal in the early position of 3, that is again you can use for the epinucleus removal, because you are using basically very low energy. Most of the work is done by the vacuum mode. Also, there is something known as a hyper burst mode that is available in the few machines, even in the peristaltic. Which sir showed his last video was done on the hyper burst. Even with the hard cataract, the sculpting itself was done on the hyper burst mode. Now you know there are various kinds of the Phaco tip. The basic principle you should know about the Phaco tips is larger the angle, better is the cutting, and the smaller the angle, better is the hold. So depending on your comfort, you can use. Initially, if you don't know which needle will be good for you, you can of course go with the 30-degree needle, which compromises for the both cutting and the holding. There are various designs that every company comes with the different their own tips, but you can use whichever is comfortable to you. Now talking about torsional Phaco, this is a small video that we have tried creating, in which it shows a torsional plus longitudinal Phaco. That's what is happening. It is similar to a sprinkle that is there in the garden to give water. So it gives the flow even in the longitudinal direction and in the torsional also. And on the left side you can see it is only longitudinal that is happening. So this is what happens actually inside the eye. Moving ahead, there are multiple difficult situations. Knowing your phaco-dynamics well, you can actually use them in the different kind of the cataract. The small pupil and the hard cataract will be covered by the madam. I will be talking about the soft cataract and the subluxated ones. So you know posterior polar cataract, there are always high risk of the weak posterior capsular tear and nucleus drop, and there are very basic principle golden rules of the posterior polar cataract that need to be followed, that you need to avoid hydrodissection. Hydrodelineation is the best. You need to maintain the anterior chamber, low vacuum and the low flow rate, because you don't want to increase the IOP suddenly, and the vitrectomy has to be standby. So this is one posterior polar cataract. You can see the entire of the lens is clear. So what happens, the entire of the lens is very soft in this. So after doing the hydrodelineation, you actually try to prolapse the nucleus, but whenever you try to do phacoemulsification in this, ideally the non-rotation technique of the nucleus that has been advised, because more you rotate, more the chances that you cause trauma to the posterior capsule. So in such cases, when you try to hold this clear lens with the phaco machine, it is very difficult. You can actually keep your pulse very low with the duty cycle of 20 or 30% and try to take a suction of the complete phaco. In this, see, we are trying to do something known as a saucer shaped cut inside the nucleus that has been separated from the epinucleus, and with the saucer shaped cut, it's actually easy to flip the nucleus completely. And once you flip the nucleus, try to take it out in the anterior chamber. You can use your Phaco 2 with the vacuum without using any emulsification, as lens is clear. You can take out the entire of the nucleus. That is what been done here, and not touching the epinuclear plate at all. This is the nucleus that is been fit. Your chopper plays a very important role in this. This is what we can do. Subluxated cataract, as you know, again there are problems of the dropping of the nucleus in the vitreous cavity and the suboptimal visual recovery, and sometimes a secondary surgery for the secondary IOL. So there are again some golden rules that need to be followed, that your incision should be away from the zonular weakness area. Your CCC should start from the healthy zonular area, and it should be centered on the lens and not centered on the pupil, and the CTI ring need to be used. So again I am showing you two very simple cases of the subluxated cataract that we have used. Again, you don't have to change a lot of your anterior chamber pressure. Your IOP should be very stable. In such a cases, if you have a very high end machine, you can always keep your IOP of 30 or 40, not more than that, because we don't want to put a IOP of more 60 and 70 and then cause more damage. And in this case again, you just try to, the most of the lens is clear in such cases, so you just try to take out the nucleus. Keep your phaco tip in the safe zone. Don't go into the zonular dialysis area, because then there will be more chances that you will end up doing more damage. There is one more similar case. Again, after following the same basic principles, we try to prolapse the nucleus into the anterior chamber, and keeping your aspiration flow rate very less of around 25, then you try to take out this kind of nucleus. Mind you, not to use much of the phaco power in such cases, because that is not going to help at all. You will end up having the whole of the bag in the phaco tip itself. So with the minimal vacuum and the minimal aspiration, you can do such cases very well with whatever technology or whatever machines you have. Thank you.
Thank you, Sumit. You have seen the how you can use the different modalities which are there in the Phaco, and you can do the successful Phaco. Now the another speaker is Dr. Ragini Parekh. She is a professor and head of ophthalmology in Grant Medical College, Mumbai. She has operated more than 85,000 cataract surgery, and she has done more than 40,000 phacoemulsification, and she has an experience of handling all type of cases. So she will talk about the handling the hard cataract with the technologies, new technology, hard cataract. Dr. Ragini Parekh.
Thank you, Padma Shri, Dr. Lane sir. Thank you for being my teacher, Dr. Navneet Toshniwal and Dr. Sumit Lane, all my teachers and friends in the audience. So, handling hard cataract with new technology. We are always faced with hard cataracts in our practices in India, because people come to us at a very late stage. And also because we are a tropical country, so the men who work outdoors come with nuclear cataracts, so we cannot get away with grade 1, grade 2 cataracts at any given day. I have no financial interest in the presentation. So we are faced with white cataracts, again because people come thinking that it should be operated only when it is mature. So we are faced with white, mature or hypermature, even intumescent cataracts. In these type of cataracts, the problem is that the capsule is not seen because the cataract is white. There is no glow for the rexes, and because of the weight of the cataract itself, many a times the zonules are very, very weak. So what are the managing strategies that we all use? We do dye-assisted rexes. I have seen people use dye also for immature cataracts, but for mature cataracts, whether you are doing SICS or phacoemulsification, dye is an absolute must. It is very simple to put dye inside the eye after putting in air and washing it out after 20 seconds. We have to be very, very careful to do very gentle hydro procedures, because many a times these cataracts have matured from a posterior subcapsular cataract. So we do not know what the type of cataract is. So either gentle or absolutely no hydro procedures in case of white cataracts, and always have a CTR ring standby of many things that should be used in emergencies, like CTRs, standby IOLs, rigid IOLs are a must in your OT repertoire. So this is a patient, as you can see, of a white cataract. This is a corneal tunnel phacoemulsification. After doing the steps of rexes, as you can see that this is a trench. Now in these type of white cataracts, a proper, complete, large trench is important, because the cataract is thick and the nucleus is bulky. After the first division, as you can see, this is the second division. This is the stop and chop technique, and the second piece is also emulsified. So you have to use the efficient use of Phaco power. This piece is now rotated and brought to face you, and the third piece is chopped. The efficient use of the chopper is very important to feed the pieces, and a proper machine with good followability, as you can see over here, is extremely important for a good Phaco emulsification. As you can see over here, this video also shows the AC maintainer and the aspiration cannula for the further steps. So this is again another video where you have a white cataract, and also the patient has a small pupil. Some part of the cortex is aspirated, as you saw here, so that you can directly access the nucleus. Now you see here, we are trying a Nagahara's chop, but it may not be able to pierce through, so you have to do a trench. You have to do a longer trench, but you have to remain safe within the margin of the pupil and in the safety of the central capsulorhexis. And then once the trench is deep enough, you can divide the nucleus. The first division has to be complete. So as you can see here, to complete the division, we rotated the nucleus 180 degrees and then completed the division. After the first division is complete, the nucleus is chopped by using a chopper into two more pieces. Either 4 pieces or multiple pieces can be made depending on the size of the nucleus. The apex of the piece is turned and fed, if you can see here, with the help of the chopper, because if this apex points downwards, you can have a PC tear by the sharp tip of the apex. This nucleus is now emulsified gradually. Again, this is the second piece which is fed and rotated to bring the apex towards the mouth of the Phaco. The piece is rotated and held with the Phaco tip. The followability is very, very important. And then the nuclear pieces are chopped. So you can make multiple pieces on chop it. And so this is the stop and chop technique. Direct chop may not work in this case. Trenching is very, very important. As you can see over here, there was a minute's pause before the nucleus, the Phaco tip was removed over here in this video, because if you remove the Phaco tip suddenly, there can be decompression and the posterior capsule rupture can occur. So that is very, very important. The second type of hard cataracts are the brunescent cataract, or the Hout brown or the black cataract. Again here, there is no glow for rhexis. Because the nuclei are hard, we are going to end up using more Phaco power or ultrasonic energy. So therefore, there is likelihood of more endothelial damage if we are not careful. Trenching is difficult, and always there is a risk of a posterior capsular rupture. Again, the management strategy includes the dye-assisted capsulorhexis, generous use of viscoelastic because you want to protect the corneal endothelium and the epinuclear plate also. And since the nucleus is very, very thick, it consists of a large volume of nuclear fibers, out of which the posterior plate is leathery and interdigitating, and they do not separate. Separation of this plate is very, very important. And the use of the burst mode. This is the efficient use of Phaco power energy to minimize endothelial damage. So as you can see over here, this is a corneal tunnel being made. This is a black or a brunescent cataract. Rhexis was made. Trenching is very, very important. And as you can see over here, this is separation. Now as you can see over here, you have to be very careful. Now you rotate again and separate this half after trenching. So you might have to take a little bit of time. These are the posterior interdigitating leathery fibers. Very gently they have to be separated without pushing the nucleus. Unless and until a complete separation occurs, these pieces will be entangled within each other and they will rotate and cause a PC tear. So complete separation is very important. As you can see here during Phaco emulsification, that the nuclear pieces are hard and leathery brown. They take a little bit of time to get Phaco emulsified because they are not very soft. So this is the second part of the nucleus which is rotated and brought in front of the Phaco tip, and then the chopping is done. So you have to be very careful. Even here, as you see that these pieces take a little bit of time to separate. Again, there is a posterior leathery plate present of interdigitating fibers, and you have to emulsify the nucleus very gently, very safely, with a little bit of time, and always keeping safety in mind. So this is the fourth piece or the last piece. So many times multiple pieces have to be made. Even while emulsifying these pieces, as you can see, these pieces are broken into small parts, and then they are emulsified. This is the aspiration cannula, very well known as the Lahane's cannula, for irrigation and aspiration of the cortex. So this is a second case, as you can see, by the Centurion machine. Again a hard cataract. As you can see, this is a cataracta nigra, and you have to use trenching comfortably to be able to divide the nucleus. Trenching has to be long and deep, but always within the capsulorhexis. A long trench is necessary because the whole of the nucleus is bulky, not only the center thick part. So again, you have to rotate the nucleus and divide it into two, because just by one you may not be able to divide the nucleus. One must always remember over here that a proper use of energy is very important, because if you are not using optimum energy and if you are using low phaco power, then you may mechanically push the nucleus and cause zonular dialysis. So in cases of hard cataracts, you have to use more phaco energy. It may be 60, 70, not less than that. Otherwise, there will be zonular dialysis. You can see the interdigitating leathery fibers over here, which are separated. Once the fibers separate, you can see a red glow, and you can see your posterior capsule, and there is no epinucleus, because the whole of the nucleus or the whole of the cataract is the nucleus itself. So this is the second piece, which is emulsified. While emulsifying the pieces, the apex of the piece is always towards the phaco tip and not towards the posterior capsule. These pieces with a chopper are gently fed into the phaco tip, and they are also cut into small pieces, because the whole piece cannot be emulsified as a whole. As you can see that these type of nuclei take a little bit of time to get emulsified. Hence, to protect the corneal endothelium, a good viscoelastic remaining in the pupillary zone is very, very important, because otherwise there will be endothelium damage. So I have already said that a generous wise use of viscoelastic is important, and leathery fibers, as you saw so well in these videos of Dr. Lane sir's, are there, and they have to be separated, because if they are not separated, the anterior part of the nucleus may separate, but the posterior will not separate, and half cut pieces will rotate into the capsular bag, will tear the capsular bag or the posterior capsule, and we will land into trouble. If the first division is complete and very good, you are halfway home. So that is very, very important. First division may take a little bit of time. If only where you are trenching and in front of you only half of it is cut, you have to rotate and then trench some more. So that is very, very important. So these are the various machines that you can use today. A large variety of machines are in the market, but you have to use a machine which makes the maximum and the most efficient use of phaco. Dr. Sumit and Lane sir have already described proper fluidics and dynamics to use this efficiently. So does the machine matter? Yes, it does matter, because you have to use a machine which is efficient. Viscoelastic is very, very important, because it protects the endothelium. If you have endothelial damage and if the cornea is hazy, there is no point in doing a phacoemulsification. But it will not protect you from other risks. You have to be an experienced surgeon. Experience does count. That all of us, when we started phacoemulsification, we considered that stride keratitis on the next day was a given thing and it was normal, but we know now today that a clear cornea with a great endothelium, a circular pupil and 6/6 vision to the patient on the first operative day is what our motto is and what we should aim at. The take-home message is that you use a high-end machine. A high-end machine need not be a most expensive machine, like sir has already told you that he showed a phacoemulsification by the APA machine in a white cataract, which is so efficient. So it need not be very expensive. A sharp new tip stop and chop technique because the Nagahara's technique may not work, effective use of ultrasound energy, that is use of a good phaco power, and choose what is effective in your hands, what is best in your hands for the best results in patients. Thank you so much.
Thank you, Dr. Agini. I think she has spoken very well, because whenever we are doing the phaco emulsification, we always stuck in the hard cataract when it is there. Then we have always a sleepless night after the surgery. And the newer modalities definitely can help you. Now I am asking Dr. Navneet Toshniwal, who is an excellent phaco surgeon from Solapur, and he will talk about the how managing the anterior chamber can give better outcome in phaco emulsification. Dr. Navneet Toshniwal.
Good afternoon. First of all, thankful to Dr. Lane sir, Dr. Ragini madam, from whom I have learned so many things, not only as a part of instruction courses, but whenever they are going to do the CAM cases also, I try to accompany them and I try to learn from them. Just now we have listened to three important points of these advanced phacofluidics that phaco machines sir has explained, phacodynamics Sumit has explained, and then how to proceed for the hard cataract. I am going to talk on something different, that how this anterior chamber depth is a crucial factor. Means it is not concerned with it's a machine, everything is important, but finally if your chamber is nice, suppose a deep anterior chamber, if it is shallow anterior chamber, how to move, how to do phaco in such a cases. Start. This is a case of a deep anterior chamber and everything looks nice. Now you start doing the capsulorhexis. You can see the phaco fluid, you can see the active visco has come out, although the chamber is deep and nice. One of the interesting point here is that when you do the capsulorhexis, means when you do the nucleus emulsification, your site of incision and site of nucleus is away from that. So that's very important, that you are working here and you are working in another plane. The difference between the two planes is more in a deep anterior chamber, and that is a very important considerable factor. Then it's a routine case, a trench, a division with the Toshniwal pre-chopper, and then another important aspect here, again take a correct position to emulsify this. One of the important point here, you can do stop and chop. Here nucleus is not very hard and your chamber is deep. So you can try to remove these pieces in toto, try to bring at the level of capsulorhexis and try to emulsify, try to core the hard part and automatically soft part will come. Another very important part here is we are using the Kelman tape. If you will use the straight tape and distance from the incision port to nuclear plane, it is more. When you use the Kelman tape, automatically that distance will cover by the Kelman tape. So that is very important if it is a deep chamber, because these are the many conditions nowadays. High myope, automatic deep chamber. So these are very important to use the Kelman tip in this situation. Go for the other piece, slowly lift it out, and you can comfortably remove the half piece of the nucleus without chopping at all, because the chamber is nicely deep. You are well away from the cornea, you are well away from the capsule, and this is the very important point, that you can, there is a big space for you to move with, and the phacofluidics will always work fantastically if only one instrument is in the eye. So anterior chamber, and another point means another little bit difficulty in such cases of a deep anterior chamber, focusing is the always problem. When you try to focus the anterior chamber plate, you try to focus the anterior capsule, there is maybe difficulty to focus because the distances are long. So that is the difficulty. Continuously you have to focus with the microscope, in this case, in this situation of a deep anterior chamber. Another point which I have mentioned, that deep anterior chamber is many times associated with the hypotony. And in hypotony, that is the tendency of the eye, is that when you emulsify the nucleus, now in this case it was very simple case, but when you do the hard cataracts and all that, some pieces may go hide behind the iris because of the hypotony. So after that, so that's deep anterior chamber, you try to just see that, check that any pieces has remained or not in a very mild modes of the energy, and check, this is just what I am checking, and try to remove. Now this is the coaxial irrigation aspiration to remove the epinucleus and cortex, which I have already mentioned that all these steps are very comfortable because you are having the very large spaces between the cornea, capsule and iris. So comfortably you can remove, that is very important. Now the next step is the intraocular lens implantation. Many times when you are putting the intraocular lenses, because of this vertical space is more. Now in this case, this is the hydrophobic lens, it has gone flat. Most of the time these vertical lenses will go like vertical like this. So that may be the scaring point, because chamber is deep. This is the presumption of the mind before the start of the surgery, and it may go vertically, but nothing to worry. We have to place it quickly parallel to the capsule, parallel to the iris border and thing. Now this is another important step. Why all these things are? Now we have put some viscoelastic, chamber is full, deep. Now you have a patience to remove all these viscoelastics, because here if you will be in a hurry or shortcut to remove all this, some part may remain there. So you have to spend more time to remove the viscoelastics in the chamber behind the lens. So you should spend, that's the variation of the chamber depth, what you have to look when you do the phaco surgery. I will try to remove, placing at the most of the time touching the lens. You can go behind the lenses. This is all very easy in this situation, but you have to remove viscoelastic because that may give the inflammation and all that. Now this is a case of another situation is the shallow anterior chamber. Shallow anterior chamber is a really big challenge. Whatever the machine you are having, whatever the, because the space is very small, and if you will not take the indicated cases for this situation, you may damage the endothelium. So this is very interesting situation, and you have to be concerned with the many findings. This is the associated with small pupil. Now you can see here, see, once I start just putting the cannula even, the viscoelastic is coming out. So I cannot form it full. And that is the one of the important. If it is a shallow AC, sometimes we feel that we want to make the anterior capsule flat and flat. We try to put more and more viscoelastic. That's not the way. You have to put viscoelastic adequate or little bit less quantity on the anterior chamber to complete your capsular axis perfectly. This is another, this is not very important that what I am doing is the sphincterotomy. No need to do this much sphincterotomy, just little bit tiny sphincterotomy. Just little bit tiny sphincterotomy, not to dilate the pupil, but very important that plane of the iris will go back. And this is what the very good advantage, very tiny, so that it should not look ugly, it should not affect your quality of the vision also. Here I have cut little bit more, but you can cut still less and small, which is you cannot see post-operatively also. Now chamber has gone deepened, and then you can try to do the capsular axis within the margin of the pupillary area. That is very important. Don't go behind the pupillary area, otherwise that small pupil will again a problem. Most of the anterior chamber shallow anterior chamber is associated with this small pupil. Again, a central trench, stop and chop technique and division. No more instrumentation, no more handling in the things. That is important. So it's a with one-handed technique only we try to do. Now here the point is that you have to use chopper. And when you will try to use more instrumentation, your AC can get shallow still. That is very important when you are doing a hard cataract and all that. You need. But here we can do the same way, that lift this piece at the level of capsular axis border and try to go to the edge. What the Ragini madam has mentioned perfectly, that you should have an apex in front. Now when the whole piece is there, you are away from cornea. Here the technology counts, here the machine counts. It's a Kelman tape and it works torsionally. It's work horizontally. So just go at the level of capsular axis, go at the edge and just try to eat it away from, and here we can use the bevel down direction of the phaco tip. In a longitudinal phaco or traditional phaco, you cannot do the bevel down position of the phaco tip to remove the pieces. Here in a torsional technology, you can do bevel down, it cuts beautifully at one point and you can engulf the half side of the nucleus in toto. So these are some of the modifications we can do, although it may not be a mention, but you can think and no need to move the nucleus more and more, lift it out, go to find out the edge and you can try to emulsify with the bevel down technique of the, and again a Kelman tip. Kelman tip is really very important to add to this session, that we have to start with the Kelman tip now, because the distance between incision, which I have mentioned already, that incision and nuclear plane is comfortable and you will work nicely away from the plane of the cornea, away from the PC plane, and that will give the fantastic results. Again, a coaxial irrigation aspiration, AC is shallow. Many times iris can see, you can see here suddenly the iris has come towards the pupillary area. So that indicates that really anterior chamber was very shallow, and keeping the watch on iris behavior is very important throughout the process in a shallow anterior chamber, because iris prolapse is a very common, and in this situation I have done a limbal incision to control on the iris perfectly, and these are the important thing. So finally, what is the important thing is that anterior chamber depth is finally very, very important to judge it during the surgery. Even in a shallow anterior chamber, just now I have shown, many times you will feel that it is associated with the shallow bag also. So you cannot play casually, and these are the very important factors. Although we are having the beautiful machines and everything also, finally anatomy is very important, concepts are very important for the better outcome. Thank you, sir. Thank you.
Thank you, Navneet. Now I will call upon Dr. Ragini to speak on the phaco in the small pupil. What Navneet was telling, whenever we are doing the phaco emulsification, the pupil, the anterior chamber becomes very shallow, and that time we never understand what is happening. So the total iris diaphragm come forward, also the posterior capsule come forward, because sometimes you get the vitreous bulge. So he has very well demonstrated. Dr. Ragini Parekh, who is going to talk about the small pupil phaco.
Thank you, sir. So small pupil, again, one of the problems that we face every day, because the pupils do not dilate. No, it's not moving from you. So there may be various reasons why there is a pupil which is very small. A small pupil is something which is less than 5 millimeters. We are used to a fully dilated pupil when we do surgery because that helps us in our surgery. There may be many causes. It may be functional, it may be a sclerotic pupil, pseudo exfoliation. The problems that you face are that it is difficult to do a rhexis. And even if you do a rhexis, because you will do a rhexis within the margin of the pupil, the rhexis will be small. And the other problems that may be associated with a small pupil and a bulky nucleus. PC tear, because you may not be able to see what you're doing. Good afternoon, Dr. Amar sir. So the king in ophthalmology. Amar sir, please come and sit on the dais. So problems in IOL implantation because you cannot see the bag completely and you may not be able to put the IOL inside the bag. Zonular weakness which is associated with it. So there are lots of management strategies for a small pupil. You start with using dilating drops. When you have seen the patient in the pre-operative time, when you are assessing the patient for cataract surgery, you are mentally prepared because you know that this patient's pupil do not dilate. So you take more effort to dilate the patient's pupil. You use intracameral epinephrine. Viscomydriasis, because with a heavy viscous fluid, the pupil dilates slightly. Lots of devices are used to dilate a non-dilating pupil. As you can see over here, these are iris hooks. They are gentle wires which pull the iris and the Malugin ring. So this is a pupil expander. Sphincterotomy, as you have just seen in Dr. Navneet's videos, and you have to keep a CTR ready. What you do in the management is you use a vertical chop. All the parameters that you use are lower than normal. You try to do a slow phaco because you might end up chewing up the iris or the pupil itself. Emulsification in a safe central zone is especially important in case of a small pupil because if you try to put your phaco tip inside or under the pupil, you do not know what you are doing and you will definitely end up with complications. And always a liberal visco use, I believe. So a low bottle height, low vacuum flow and aspiration, less height, less dynamic water flow inside the AC and less changes, so you have a stable AC, otherwise the AC diaphragm, the iris diaphragm keeps moving. Torsional phaco gives you a better grip, a hyperpulse or a hyperburst mode and a safe zone phaco. Safe zone phaco I think is the mantra for any type of cataract surgery. As you can see over here, this is a very small pupil and we are using the capsulotomy needle to slightly enlarge the pupil without causing any tears. And we are using, since it is a mature cataract, we are using a dye to stain the capsule and to do the capsulorhexis. As you can see over here, the capsulorhexis appears to be decentered, but it is not the capsulorhexis which is decentered. The pupil has dilated a little more towards the side of the wound and less dilated on the other side. That is why it appears to be eccentric. The chopper is used to retract the iris slightly, and always the phaco tip is not moved from the center. You must not go haywire with the phaco tip. If the center divides, the periphery of the nucleus will divide. That is the mantra in phaco emulsification because it is the center which is the most hardest. So you make multiple pieces remaining in the center safe zone, as you can see over here. Rotate the nucleus, make small pieces with the chopper and chopping, and just go towards the piece. Once the piece is held, it gets aspirated towards the phaco tip and then it can be emulsified. Slightly above the iris plane, but definitely safe because otherwise you cannot see what is happening. So phaco emulsification is possible. So this is a second patient. Here you can see a corneal tunnel and a festoon pupil. So these are again type of cataracts that we are faced with. So you take the capsulotomy needle and gently break the synechiae while pushing it under the iris and gently using the needle to break the adhesions. So this is very important before you attempt a capsulorhexis, because once the adhesions break, as you can see over here, the pupil expands or opens up slightly. So in a patient of a complicated cataract who already has synechiae, again the use of a capsulotomy needle to gently open up the pupil. So the pupil now is a little more dilated than it was when we started with. A capsulotomy is within this dilated pupil, it will be less in diameter than what you normally would do, but it is important to be safe, because if it is under the pupil, again you do not know what you are doing. So this is all pigment which has dispersed during the capsulotomy, which will anyway be removed. Gentle multiple point hydro maneuver, it's very important. And this is phacoemulsification, trenching in the central safe zone of the capsulotomy, and with a trench which is a first division, so that is a stop and a chop. Then if the center divides, the periphery will divide, taking the apex of the of the nucleus piece and emulsifying it is important. So phacoemulsification can be done because you are still in the central pupillary zone. So as you can see over here, it can be done. You do not need a large pupil to do phacoemulsification if the center of the nucleus divides. So this piece is now rotated and brought towards you and chopped comfortably, and then it is emulsified. So as you can see over here, chopping takes place and small pieces are emulsified. One must notice that you do not move at all from the center with the phaco piece. The phaco piece remains in the center. So this is the use of the AC maintainer and the aspiration cannula for safe removal of the cortical material. So small pupil also can be managed. Various devices can be used even without using any device. If the center of the nucleus divides and if the phacoemulsification is done in a central safe zone, a complete good phacoemulsification with great results as possible. Thank you so much.
Thank you. Thank you, madam. With the excellent demonstration how central safe zone has to be maintained. Before talking, sir, madam, what is your opinion about the iris hooks and all that?
I do phacoemulsification by using the chopper to retract the iris, and I have I think all the devices like Malugian ring or iris hooks and all. See, it is important that the patient remains safe. So you have to know the use of these devices, and you must remember not to damage the iris, because atonic pupil will cause glare, and everybody, otherwise, and however the surgery is, if the patient sees an irregular pupil, he is going to worry and there will always be glare. So what is important is the proper use of these devices for good results.
Thank you, madam.
Okay.
Now again the Lanesh sir, who is going to talk on
Again now I welcome you after the lunch, and the Amar, who is my friend, my philosopher, guide, who is there. Ragini did very well about the small incision, and also the Navneet. Now here this is I want to show you the which machine which was not opening here. Now see what I was telling you before going to my topic. Now see, I am doing the chopping, and in the chopping, see my this is upside down, and see the chopper. So the chopper is not in the line of the phaco tip. It is slightly away from the phaco tip. Always remember, not in the same line. Now you see I am rotating this, and once I rotate, can you see again? Can you see here? Now I am chopping it. You can see the bubble as I am using the both longitudinal and all. Now you see here again. Can you see the and the chopping? It happens not straight to the this one, but it happens to the. You can see here again. Can you see here? Now see my phaco tip is here and my chopper is here, and this is you can say also you can design the artistic design. You have the 6 small pieces again. Now see here, and whenever you are making the pieces, those pieces should come up to the middle of the nucleus, center of the nucleus. It means those are separated. Or if otherwise, now if you are making, now see here, this is the line and this is the line, and once you enter, this is the chop. I am making the vertical chopping here. Again you have to, now again you rush inside. Now see, going here, bury the tip, and once you bury the tip, then you make it separate, and the piece should be separated completely. So wait, so just you have made a piece, and without separating it up to the center, if you have, now see, if you have left it, then that piece the fibers which are posterior fibers, they will intermingle in the removal of the piece and piece will not come. You will think why piece is not coming, and you will get the PC tear, because that posterior fiber that will make the piece upside down, and the tip of the piece will tear the PC. And so for that you will have to separate it completely. The complete separation of this is very much required. Now see here, I am doing this, and can you see this? So why it is coming? Because there is a total separation of the piece, and once I have separated the piece, then you will have to again catch. See the piece here, it has gone away from me, but still I am doing the removal of the piece gradually, you can see, supporting by the chopper, and the piece is removed. Again the piece will come. Because of this occlusion phenomena, piece will come automatically, and see that other 3 pieces are behind my Phaco probe. So now I will rotate those pieces, and as you know, this is the matured cataract, no support. So you will have to rotate it very gradually, and once you rotate it, again you see this is coming, and here you can see it was not separated here. Separation was not there. I have separated it now, and then I will emulsify and aspirate it. Again you can see here, again I will aspirate. See the last piece, once remains the last piece, then you should be very slow. Now see here, the last piece going very slow, steady, and then you see again the small pieces are remained, but here you have to reduce your vacuum and also the Phaco power, and then the last piece you can remove it. See here, and once you remove that totally, wait, and then you come out, see. So this is what happens in the, and then I will go to the one more. I want to show you the stroke length, but I am not finding the video. We will go for the this one, my PC tear, that is a posterior capsular rupture. See the posterior capsular rupture, always we worry for that, and we should worry for that. Now see the posterior capsular rupture managing by the anterior segment surgeon. Say, I always say that if there is no posterior capsular rupture, then our colleague will not get the food. So there should be posterior capsular rupture in our surgery, so that the retinal surgeon, we can feed them, because we are the cataract surgeon, and we must be sympathetic towards all the peripheral surgeons who are there in the ophthalmology. Now there is no any financial interest. Now see, what are the risk factors? So whenever there is a Phaco, what I always feel, that Phaco means fast. So Phaco starts from P, not from F, and because of that, Phaco is not fast, but Phaco is a procedure which should be slow. Now the risk factors are lens related risk factors, then the ocular conditions, then the systemic conditions, and the machine related risk factors are there that can cause the posterior capsular tear. Now see the lens related risk factors are the mature white cataract, intumescent cataract. Then in that the rhexis may not be proper, black cataract is there, the posterior polar cataract. Then the cataract, it is age of the cataract is longer duration, history of trauma is there but not seen properly, and the previous vitrectomy. So that can cause the problem. The risk factors which are ocular conditions. Now in that the deep orbit, in ophthalmos, corneal opacity, shallow anterior chamber, or small eye, high myopia, myotic pupil, posterior synechia, iris atrophy, or the floppy iris syndrome, or PXS, weak zonules, or anterior capsular tear. Then the risk factor systemic conditions. Now in this the inadequate anesthesia with the excessive movement of the patient. The neurological and mental disorder generates the involuntary movements while operating. Then the cardiopulmonary diseases that impairs the flat position of the heavy breathing, impossible to the patient. Obesity and short neck that can produce the increased vitreous pressure, and age of the patient. Then the machine related, can see the operating microscope related or the phacoemulsification machine related. And so the diagnosis, how you diagnose, because of this it has happened. Sudden deepening of the anterior chamber in one quadrant, one area, it is there. Iris prolapse during the hydro dissection. This means that the blowout capsular break. So because of the hydro, there is a blowout and then anterior chamber becomes very shallow. We are unable to go in, means vitreous is there. Then the meiosis, failure to rotate the nucleus, decreased the flowability, then tilting and displacement of the nucleus which starts to sink into the vitreous. Now the management. Now the management depends on the primary, depends on the nucleus, epinucleus or cortex, what is remaining. Then the secondary, the vitrectomy or IOL implantation, and tertiary is a VR referral. Now once you come to the nucleus, I think you have to see the nucleus dislodging, or you can remove the ISCO expression, or the phacoemulsification, or chopstick technique, vitrectomy, or by the scaffold. Amar is sitting here, or without scaffold. So the nucleus can be managed by these 7 techniques when there is a PC tear. Now the epinucleus can be managed by the visco or IOL scaffold, suction or vitrectomy. So 4 techniques can be used when there is only the epinucleus is there. When the cortex is there, you can use dry suck and spit, synco cannula, irrigation aspiration or vitrectomy. You can use the 4 techniques for the cortex after PC tear. Now when there is a small tear, then what we should do? No vitreous loss, small tear is there, then you can go for the PC IOL in the back, as there is no any vitreous. Then the vitreous loss is there in the small tear, then anterior vitrectomy with IOL in the back. You can go for the vitrectomy with IOL in the back. If there is a large tear, now in the large tear, now the no vitreous loss, then the PC IOL in the back, you can go for that. If there is a vitreous loss, then you can go the adequate back support, or circular capsular axis is there or not, that you will see. And then anterior vitrectomy, IOL in the back or sulcus, that according to the support available in that case. Now in that, the inadequate back support, if the back support is inadequate, then what you can do is nucleus plus cortex removal, the back support is less, nucleus per cortex in the vitreous cavity. Then what you will do? Vitrectomy plus iris or scleral fixation of the IOL. So when it is support is not there, you will have to go for the iris supported lenses, and then you can go for the anterior vitrectomy for IOL or VR referral. So all these things you can have a large tear. So if this chart is there with you, you will come to know what happened and how you can manage the vitreous loss if it is happened with you. So chart will help you whenever you are managing such type of vitreous loss, small tear, large tear, the cortex is there, epinucleus is there, or the nucleus is there, and where it is. This will guide you whenever you are on the operation table. Now this is the Amar should see this now. See Amar, I was operating and see now there is a PC tear, and here the Amar will not agree with me, because see this lens is one piece foldable lens. So whenever you are using the scaffold, it should be 3 piece. But I was operating out, there was no 3 piece available with me. And then I thought, yes, the scaffold I can use the 1 piece lens, I have implanted the 1 piece lens behind. And now after that, whenever you are basically go for 3 piece lens, because the here that will having more strength than the 1 piece lens. Sometimes this 1 piece lens may go this one in the PC only. So it is better to go for that. Now see again behind. See now the lens is there and I am doing, but here you will have to protect the endothelium, because you are not in the posterior chamber, you are in the anterior chamber, because lens is in the on the sulcus, that is in the sulcus. So here, so whenever you are doing such type of thing, then you will have to do the aspiration and also the vitrectomy. See the cutter you will have to use, and the whatever the material vitreous is there in the anterior chamber, that you will have to cut. Unless and until you cut the vitreous, you should not finish the surgery, and that will definitely help you. Otherwise, patient will have the photophobia continuously. This photophobia is because of the vitreous in the anterior chamber. So you will have to manage that, and then this lens will definitely help you. Now another thing is the secondary, that is the vitrectomy and IOL implantation. You have seen the primary management, you have seen also the chart also you have seen, and now you will come to the another thing, that is a main incision, vitreous cutter and the side port, the irrigation handpiece, that is a bimanual technique. You can use the triamcinolone acetonide to visualize the vitreous in the anterior chamber, which is very, very important. Then what happens, then when you are thought about the what lenses you can use, you can use IOL in the back, you can use IOL in the sulcus, you can use the scleral fixation IOL, that is a or you can use the glued IOL of the Amar or the iris fixated IOL, and I am against with the anterior chamber IOL, because the anterior chamber IOL definitely will endothelium will be damaged after few years, and you will have to remove that anterior chamber IOL, and also you have to go for keratoplasty. So that is an iatrogenic blindness. So I am very much against that, and no IOL. I think if there are so many things are available, then why there should be no IOL? So what I feel is these two options should not be there, and all other options can be utilized when there is a such type of thing. And now the IOL in the bag or sulcus, see indications in case of small capsular tear with a good capsular support, where the highlight phase has been disturbed, the precaution is inflate the bag with the viscoelastic and do not dial the IOL. If you dial the IOL, then that you will have to put that IOL with the forceps, and once you dial, that will go down, because the other limb will also go behind the not much supported or elastic bag. The choice of the IOL is PMMA or foldable hydrophobic acrylic 3-piece IOL. This should be the only choice. Can go for the 3-piece or PMMA. And now to prevent the decentration of IOL optic capture can be done. The haptics are in the bag, optic is outside the bag. So you can keep the haptic in the bag and optic outside the bag, or you can have the haptics are in the sulcus and optic is in the bag, that is to the posterior CCCC. That can be, that is called as the lens capture. So that also you can do whenever you are doing the such type of lens. Now the tertiary management, that is a VR referral. When there is a tertiary management, always remember the VR person should be your friend, and he should not talk to the patient, otherwise he will say that your eye is spoiled by the surgeon. So he should be a faithful friend. Always remember, only one person troubles in your life, and his name is friend. So the choice of the friend is very, very important. Who is the friend? That who talks good about you behind you. When you are not there, he talks good. You just see that in the atmosphere. If he is talking good, refer the patient to him. He will operate the patient. Otherwise, if he is not getting good result, he will blame. He has only made this, he has spoiled the eye, I have tried to save the eye. And lastly, the patients and relative will not come to us, they will blame us, and they will go in the court of law. Now here you can see the draft nucleus. The anterior segment surgeon is advised to implant and sulcus foldable or PMMA, or to close the cataract. Always remember, when it has gone in the vitreous, no handling. Don't touch the vitreous. If you touch the vitreous, you will also there will retinal detachment, so many other things, holes and everything. Once it is there, close down the wound, come out, have a water and the tea, and see where to refer. Tell the patient that there is a problem that lens is in the vitreous, and refer the patient to the retina surgeon. The refer to VR surgeon, 3-port vitrectomy to be fragment or remove the drop nucleus or nuclear segment with the ultrasonic tip, low power, high vacuum. They are using phacopragmatome. And now here you will see the what I am making. This, see now I am operating a cataract, is a mature cataract, not this one, very hard, but you can see can you see here? So there is a PC tear. So this PC tear why happened I don't know, but now I am an SICS surgeon. When you are SICS surgeon, then I think you can help the phaco surgeon. Now here you will see I am trying to remove the nucleus, but the nucleus, you can see the nucleus here, it has gone down, and this is on that side. So what I am doing is I am using the my side port. Can you see this? How the nucleus is moving. Once this nucleus is moving, your heart also start moving, and then see now the nucleus is not seen. Now what I am doing is I am going from here, and with the repositor, I reposited the nucleus. I have hold the nucleus, and once I have hold the nucleus, see like this, I have catched it, and it was to go out, and there is a glide. I do Blumenthal technique. So by the glide, see now the nucleus has came out. It was supported by the glide. So here, but you should not go much behind. And now here I am doing. Now what wrong is here? I am doing from the large wound. So whenever you are doing the vitrectomy, you will have to take suture, and after that you can go for the vitrectomy. Otherwise, if it is an open wound like a small incision surgery, you should not go for that. Now here I am trying to remove the vitreous, whatever it is, and you can see the cortex is seen, but I am removing the vitreous from all portions behind the cortex. And then now again I want to show you, there is an excellent rim of this one. I am going to put an PMMA IOL, and you can say can you see this? I was rotating. So what I was telling is, once you are rotating the nucleus, this lens goes down. So here once the lens goes down, again I have catch that lens. That was my luck, nothing more than that, because it was a proper vitrectomy, the lens was there, and so I was able to do that. And see here, then I have just dialed the lens in the sulcus, and the lens is implanted in the sulcus, and I could do proper surgery. Second day patient is having the good vision, except SKs, there was nothing. So only thing is that whenever you are managing anything, you will have to concentrate and manage it. Whatever the things come, and now we have got the 2-3 minutes. If you want, you can ask me the questions for any of the speaker, or otherwise we will complete our session. Okay. Thank you very much. Now we complete our taken. Thank you very much.
Thank
Yes,
you,
Ragini.
sir, and thank you to Sumit for making such beautiful presentations for us.
Thank you, everybody.